the co-chairs with Nettie. So the session is about to begin in about 1 minute, and we have most of our speakers here. We are going to go ahead and have each presenter will be presenting for 6 minutes, and then we ask that you hold your questions at the end to make sure that we get through all the presenters. So our first presenter is Raymond Bayurahuhanga, who works for the USAID TB project as a project director for Management Sciences for Health in Uganda. And he's representing Halim Kadar, who works for MSH in Afghanistan, who unfortunately was unable to make it today. Let's welcome him to the stage. Thank you, Raymond.
Okay, thank you very much, Chair. This morning I'll be presenting All right, great, thank you. I'll be presenting on evaluating the effectiveness of tuberculosis care providers on treatment outcomes in Afghanistan, and it's a cross-section. This is a cross-sectional study. Thank you. So, as a background, the objective of this was to evaluate the outcome of treatment observed by different providers in Afghanistan. Afghanistan, the TB drug intake is observed by quite a number of stakeholders, but mainly the community health workers, the public and private health workers through a DOTS approach, treatment supporters, and these are usually mostly family members. In 2016, the community health workers observed about 7% of patients' treatment, while the private sector health workers observed about 10%. So as a methodology, in terms of the study, the cross-sectional study that was done, health facilities selected about in 12 regions using a randomized cluster sampling, and all patients who completed their treatment between 2014 and 2015. They used data collection tools, treatment outcomes collected from registers, from DOTS centers. The sample size was about 3,200. Total patients who completed treatment during this period were actually evaluated. The results from the 3,200 patients were reviewed, and about 2,650 patients, which is about 83% of the patients who had completed treatment during that period. The community health workers observed treatment for about 7.7% of the TB patients, and during this time, treatment success rate was about 88%, while the death rate, mortality rate was about 2%, and the default rate was 3%. Comparable to the community treatment supporters, who are mainly the family members, who actually provided treatment to about 37% of the patients. The treatment success rate was quite impressive at 71%. Mortality was 2%, and the default rate was another 2%. Transfer out was 9%, and those that were not evaluated were 9% as well. The public facilities, and which treated 34% of the patients, the treatment success rate was quite impressive at 87%, as compared to the community, which was at 71%. The private sector also supported in terms of treatment success, and had a treatment success rate of 86%, of who they looked at 35 patients. This is a tabular form of the results, and you will observe that this is comparable between the community supporters, the community health workers, the private service providers, and the private sector. You will note that actually the community health workers, in terms of treatment success rate, tended to give the highest, which was 88%, compared to the community supporters, which was as low as 79%. In conclusion, community health workers, the public health facility treatment outcomes, and the community health workers, DOTS administration was encouraged or is encouraged. The community treatment supporters treatment outcomes tended to be low, as you observed from the table, and it is recommended that engaging community health workers in TB treatment in Afghanistan and similar settings elsewhere is the way to go in terms of observing treatment. This is the end. Thank you very much.
Thank you, Raymond. Again, we're just going to hold questions to the end, though I think we're missing some of our speakers. So if so, we might clump 3 and then do questions for 3 and then move on, because I think we have some missing speakers. For those that are just joining us, this is session number 2, Improving Care and Support for Patients, the short oral abstracts. So the next speaker is Mustafa Shefa, who's been working as a technical advisor and senior project officer with Management Sciences for Health since 2009 to 2017 in the field of public health in Afghanistan, and he's currently residing in Australia, getting his MPH. Welcome to the stage, Mustafa.
Thank you. No, this is not the presentation. Exploring.
Sure, absolutely.
Yeah. Okay, thank you. The title of this presentation is Exploring Tuberculosis Services Provision and Patient Satisfaction in Afghanistan. Okay. The objective of this study or this survey was to explore the level of TB patient satisfaction of TB provision in Afghanistan. As a background, from 2002 to 2016, by massive support of USAID and other national and international donors, National TB Program of Afghanistan could increase the number of health facilities from 50 to 2,000. The health facilities were providing DOTS or TB services. These health facilities are applying TB standard operational procedures, and these health facilities have assigned healthcare worker to provide free of charge consultation and treatment to TB patients. We developed a questionnaire with a few sample questions to ask the TB patients. We randomly selected 49 health facilities, 432 TB patients across 8 provinces of Afghanistan. Yes. And the result was, out of these 432 subjects that we interviewed with them, 65% were female and 35% were male. 94% of this number of interviewees were satisfied with the current TB provision in Afghanistan. 85% of them had the chance to choose their option for treatment, either on health facility or at community level. 70% of them were oriented about the TB infection control measures at community and at their home. And 80% of them were oriented on the side effects of anti-TB medicine drug. And unfortunately, 5% of them were facing at health facilities with no anti-TB medicines. The majority of TB patients were satisfied with TB service, and 85% chose their treatment options. Yes. Despite this huge number of satisfaction, but still 30% were not oriented on TB-IC measures, and 20% were not oriented on anti-TB medicine side effects. 5% were facing with health facilities with no anti-TB medicines. So we strongly recommend the National TB Program to proper implementation of TB standard operation procedures to increase the health education and to apply successful approach like community-based DOTS in Afghanistan. Thank you very much.
Mustafa was very efficient with time, so we have a couple minutes if anyone has a question for Mustafa. You want to ask your question to Raymond?
¿Pueden dar otro micrófono, por favor?
I can hear.
Thank you very much for your presentation. I'm wondering, in terms of the patient satisfaction survey, it was a very simple survey, but how many questions and what sort of questions did you ask patients?
It was around 8 questions in 2 groups. One was about their education and their information, and the other was about their satisfaction about the TB service provision at health facility. For example, we asked them, did you choose your treatment option? Did you choose that you get the treatment at health facility or at the community level by community health workers and other treatment supporters? And also, we asked some question about their information about tuberculosis. For example, what is the major side effects of anti-TB medicine? Yes. No, they were during the treatment, yes.
All right, Mustafa, thank you so much.
Thank you.
Great. Our next speaker is Gloria Wendei, who is a grants and finance professional with experience in implementing, coordinating donor-funded programs since 2010. She's performed various grant management functions, which includes coordinating activities and resources in support of the Global Fund TB project that impacts multiple partners. Gloria lives in Nairobi, Kenya, and works at Amref Health Africa in Kenya. Welcome, Gloria.
Good morning. I'm going to present on the title, Does Physical Tracing of Treatment Interrupters Improve Treatment Outcomes? Patient-Centered Care Approach to Care and Treatment in Busia, Kenya. Next. Background and challenges to implementation. The NTB strategy identified patient-centered care and prevention as a key pillar in ending the global tuberculosis epidemic and its related burden. This pillar envisions providing care and support that is sensitive and responsive to patients' educational and emotional material needs. However, lack of supportive supervision and follow-up has resulted to high number of patients interrupting treatment and thereby risking the progression to a drug-resistant TB. Getting the patient to adhere to treatment is key to improving treatment outcome. And by treatment outcome here, we are going to emphasize on the patient outcome, particularly when you are tracing, doing physical tracing. Where am I supposed to point? Sorry. Sorry, is the support?
Too far? You need to go back?
Yeah. Intervention. AMREF Health Africa is a principal recipient, non-state principal recipient for tuberculosis grant, and we're implementing community TB. Within these activities, the projects that we undertake, we have empowered the community health workers. We trained them. 60 of them were trained between the period when we were doing this study. And after training the community health workers, we sent them out through the sub-recipients that we work with. We send them out to do household visits. They get the names from the healthcare workers. Immediately, a patient misses appointment. After 2 days, the healthcare worker singles out the name of the patient and they are sent out to go and do household visits, doing physical tracing. So 3 approaches were developed, and where physical tracing was done, calling the patients by the healthcare worker and also calling the support, patient supporter. So this is the study that we are doing now to find out the effectiveness of physical tracing so as to enhance patient-centered care. So TB treatment interrupters in Busia County were traced by community health volunteers between November 2015 and December 2016. So the study is a descriptive one, and correlational analysis was conducted to establish the relationship in the method of tracing, output, and the outcome of the tracing. Results. Among the 503 patients traced, 60% were traced physically by the community healthcare workers. 28% were traced by calling the patients, and 12% were traced by calling patient treatment supporter. Physical tracing by CHVs were positively associated with high likelihood of TB treatment interrupters returning to treatment, given that they were able to interact with the patients and were able to identify the pitfalls that made them not to come for treatment. Physical tracing physically influenced return to treatment as compared to calling their treatment supporters. Conclusion: patient-centered care was observed more often with physical tracing and associated the return to treatment. Physical tracing is an important approach for identifying and addressing patient-related barriers to tuberculosis care and treatment. Future scale-up of community TB care and prevention should include provision of physical safety and transmission protection of tracing teams. Thank you.
I think we have time for one question for Gloria, if anyone has a burning question.
Does this work? Hello? You can hear me? Yes. So what percentage of the patients who were physically traced actually did return to treatment? Do you have that number?
The total number that came back to treatment, out of the 500 that defaulted, lost to follow-up, as the results were showing.
Oh, that was 60% came
Yes.
back? Okay, I didn't
Yes.
understand. Okay.
60%.
Got it.
Gloria, I had a question. I was wondering, did you find out why they had stopped treatment? Did you find any kind of key things cross-cutting among your patients who stopped treatment, what their issues were?
Mainly, the reason why most of them were defaulting was partly nutrition, where they were feeling that the medicine were too strong and they needed, it was affecting, there was a device effect because they did not have food at the moment, and so that was one of the reasons. The other reason, like whenever we would send a CHV out for the household visit, they would tell you that, particularly the drunkards, they would tell you that they don't want to continue with the treatment, And so that meant either two results. They found the patient, and the patient was not willing to come back to treatment, and therefore another intervention had to be engaged. Yeah. So mainly it was nutrition. Yeah.
Thank you.
Thank you.
Can I ask just a small question?
Yes.
This thing is not working. Where is it? There you go. Okay. What was the effect of going to the houses related to stigma? Did people feel uncomfortable because they might feel stigmatized if they get a visit at home?
Yes, some were getting stigmatized, that is true. But during treatment, initiation to treatment, the patients were taken through all the stages, and they had to sign a consent form that they have to adhere to treatment, and failure to which they would receive a CHV visiting them at home to ensure that they abide, given that it's also a risk also to the public. So in as much as it was stigma, they also welcome, given the approach that the CHVs also adopted. Yeah.
Thank you, Gloria. Our next speaker, Momita Biswas, is working in the Union Southeast Asia office for 3.5 years as a technical consultant for the revised National Tuberculosis Control Program for Madhya Pradesh state in India. He provides technical support to the state's RNTCP on aspects of advocacy, communication, and social mobilization. Welcome to the stage. I apologize.
Well, good morning, everyone, and thank you for giving me this opportunity to present my paper. I would be presenting an analysis of how decentralization of healthcare facilities is contributing to reduction in the treatment delay, treatment initiation delay in central India. Yeah. Coming to the background, programmatic management of drug-resistant TB is being implemented in Madhya Pradesh since 2011. PMDT recommends 1 week of hospitalization for all DRTB patients at the DRTB centers for pre-treatment evaluation and initiation of second-line medications. But till 2013 fourth quarter, DRTB centers in Madhya Pradesh were functional at only 2 sites, that is Bhopal, which is the state headquarter, and Indore city. DRTB patients, as a result, found it very difficult in accessing care, which resulted in delayed treatment initiation. So with this backdrop, our assumption was accessibility to services can reduce the proportion of cases lost, as well as early treatment initiation. And is it not working? Yeah. So the research question is, what is the impact on time lag in treatment initiation with the decentralization of DRTB services? I'm sorry, it's not. Yeah. So
You want to point it towards the back.
Okay,
the back
okay,
of the room.
okay.
Is that right?
And the next one.
To the right and point it that way.
No, it's not.
Let's see.
My sampling population was the DRTB center based at Bhopal. We used a combination of both qualitative and quantitative research using record reviews present at the Bhopal DRTB center, as well as in-depth discussions with the healthcare providers. A retrospective analysis was done to analyze the time lag between diagnosis and the treatment initiation of the DRTB patients registered. And in addition, in-depth discussions were done to understand what are the facilitators and or barriers in timely treatment initiation. For the qualitative data, content analysis or the narrative analysis was done to document the qualitative responses. Yeah, coming to the research setting, Madhya Pradesh is located in central India. It is a province in central India, having a population of 79.12 million, which is predominantly rural. 70% of the population is rural. Amongst these, about 20% are tribal population as well. The state is divided into 51 districts covered by 247 PB units and 818 designated microscopy centers. Parts of the states are geographically hard to reach and with hilly terrain, so they have poor access to healthcare facilities, especially at the rural locations. Yeah. So this is the allocation of the districts to the two DRTB centers which were functional till fourth quarter 2013. So you see, this is the Bhopal DRTB center located in central Madhya Pradesh, and the second one is the Indore DRTB center. So Bhopal DRTB center was basically catering to more than 50% of the districts in the state. However, over the time, there have been more DRTB centers which have been added in the state. Now it's in 2016, the number of DRTB centers came up to 9. So the services have been decentralized, and now the Bhopal DRTB center is catering to 8 districts instead of 36 earlier. So coming to the results, I've compared two cohorts. One is 2012, the other is 2016. During 2012, only 2 DRTB centers were functional in Madhya Pradesh. DRTB center Bhopal was catering to about 36 districts out of the total 50. 90 DRTB patients were registered at the center, and the median delay in treatment initiation was calculated to be 98 days. Comparatively, in 2016, when the number of DRTB centers increased to 9. In addition, there are also district-level linked DRTB centers, and district DRTB committees have been formed which were functional. The Bhopal DRTB center now caters to 8 out of 50, and the number of DRTB patients registered is now 291, and the median delay in treatment initiation is 9 days. Overall, if you see from in the entire state, the total number of DRTB patients registered have increased from 347 in 2012 to 1506 in 2016. When we analyzed the records, we found that the patients who were living in districts away from Bhopal were more likely to delay in initiating the treatment. Qualitative analysis also confirmed the same, that the patients were reluctant in traveling to the DRTB center because it was inconvenient, even though their travel allowance was provided. Can you please go back? The second last slide. Yeah, thank you. So coming to the conclusion, our conclusion was that the decentralization of diagnostic and treatment facilities, treatment services will definitely facilitate in reducing the delays in treatment initiation. Also, there is a need for ease of access and patient-friendly services, availability of that, as well as strengthening supervision and linkages. Thank you.
Stay on track with time. We're going to go ahead and hold Ronita's questions till the end, if that's okay. So we would like to welcome Mustafa back to the stage. He's presenting on behalf of Ghulam Kadar, who cannot be here today. He's a technical advisor and senior project officer for the Management Sciences for Health from 2009 to 2017, working in Afghanistan and public health, and is residing in Australia giving his MPH. Welcome to the stage again, Mustafa.
Thank you very much. This presentation is about orphan dots in Jalalabad city, one of the cities in Afghanistan. Efficacy of drugs implementation in densely populated cities of Afghanistan, experience from Jalalabad city. Next slide, please. The objective of this presentation is to identify the effectiveness of orphan dots or private-public mix approach on TB test notification and treatment outcome in Jalalabad city. The population of this city is around 240,000. The national TB prevalence is 340 per 100,000 population. National TB incidence is around 61,000. And during 1 year, 41% of TB cases are missing. The over-intervention was to engage the public and private facilities in provision of dots or TB services, training of healthcare staff, and standardized TB recording and reporting system or reporting forms, ensure sufficient supply of drugs and reagents to health facilities, joint supervision and monitoring of these health facilities jointly with provincial health office team. The data collection tools of this presentation of this survey was entity standard reporting and reporting. The result was that 32 health facilities become under coverage of private-public mix or orphan dots. 19 of them were public health facilities and 13 were private hospitals. Health facility coverage of orphan dots is around 53% right now in Jalalabad city, 17 health facilities. Access to TB services improved by outpatient attendance or OPD doubled from around 80,000 in 2014 to around 160,000 in 2016. The presumptive TB patient identification increased by 88% from 4,266 in 2014 to around 8,000 in 2016. Case notification for all forms increased by 47% from 1,288 in 2014 to around 1,900 in 2016. And this is also the same result in graphic. If you see the trend, this is all form TB cases increasing from around 800 to around 1,900. And this is the new bacteriologically confirmed TB cases that is increasing up. Private-public mix or orphan dots approach increased the TB case notification by 47% in Jalalabad city. So we recommend the national TB program in Afghanistan to strengthen the PTM or the orphan dots approach to cover additional facilities in Jalalabad city and similar settings in Afghanistan and elsewhere in the world. Thank you.
So I think Neki had a question. I think we have time for 2 questions. So Neki, go ahead and then we'll take one from the audience.
I think it was also but maybe you can also give some more insight in the treatment outcomes.
about the increasing the treatment outcome as well, but it's not included here, but we have it. I think it's in Jalalabad city, if I remember, it's more than 87%. The treatment succeeded.
Just to clarify, Afghanistan, the TB control program also USA we are implementing 5 control programs. We allow that but in all these cities the approach is also like a indicator coverage we are facilities, private and public health facilities. Case of innovation rate that is implementation and also the business aspect. And in general, in all the cities in general and most advanced rate, the success rate is above 85%, 87%, 90%. General
Okay, I just want to confirm, is James Mpunga in the audience? Great. James Mpunga is from the Ministry of Health National TB Control Program in Lilongwe, Malawi. Welcome to the stage, James. Can we pull up James's slides, please?
Thank you very much, Chair. I'm James Mpunga. I'm Program Manager for Malawi. So I'm presenting on this presentation whereby we wanted to look at the supervision strategy that were put in place and what has been the effect in terms of care of our TB patients. So Malawi is a high-burden TB HIV country. Our incidence is 193 per 100,000 population, and our case detection rate is at 47%. The weight of TB service is very critical to every program implementation, and we also use supervision as a key strategy to making sure that the quality of care is being maintained. So the NTP implements a regular supportive supervision to all the facilities, and we started this kind of approach from 2015. And what we try to do is to look at the international standards of care and make sure that every supportive supervision is guided by the international standards of care for TB control. So as you know, these standards of care address all the thematic areas, and therefore we came up with a tool to help us collect information and interpret that information, and also help us in acting moving forward. So the method, we had to come up with that tool, and we looked at all the indicators, came up with a composite scale using all the 11 indicators in the international standards of TB care, and some of the indicators are the ones listed there, and each indicator had a maximum of 2 points, and the 0 was assigned for the least value. So these were the results of the composite scores for the facilities that we supervise, and this is for the last 6 quarters. You see that it has been a progressive increase in terms of performance of those facilities, with the median value increasing by 20% over the past 6 quarters, and this has been statistically significant. So the point is to make sure that our supervision is indeed providing the best outcome that we want by actually looking at the international standards of care. And you can see from this graph that it has been a steady increase in the quality of care in our healthcare setting. So in conclusion, regular supervision using this standardized monitoring and structured support will contribute to improvement in quality of TB care. The tools will ensure continuity of follow-up of action points in the subsequent visits because you know where the facility is. And the ones that are not doing very well, you can actually also come up with a mentorship supervision to make sure that you are strengthening them and encouraging them. Thank you very much. Yeah, that's a great question. In this setting, we did not actually look at the perspective from the patients. And I think I agree with you that if we just concentrate on the healthcare workers, we might also be missing something else. And this is a very good point that maybe when you're going for supportive supervision, we should also have some time to talk to the patients and hear from them what they're actually doing. But I think moving forward, with support from World Bank, we are going to do that. We have come up with the exit surveys that we are supposed to be doing. And moving forward, I think in the next 6 months, we're also going to tabulate that and see what that is giving us. But for the past 6 quarters, that component was not taken on board. But it's a great point. Yeah, this is also another good question. The challenge is indeed true to say that when you're doing supervision, sometimes people run away from you as a supervisor because they think you're just taking too much of their time. But what we have done is to make sure that after the supervision, we sit with the team and we make sure that they understand their own data. They should be able to interpret that data and also act on that data. This is a departure from where we're just going to collect information, to come back to headquarters, compile a report and give it to them. It's like this is just another of those duties. But when we go there and make sure that we are taking them through, for them also to understand why they are not performing, for example, in treatment success rate, why most of the patients are dying, it also gives value to them to say, okay, if we do ABC, it means next quarter when these people come, we might also get a better grade. So it's about them understanding why you are supervising and what that supervision is also going to contribute towards patient care.
Okay, so good afternoon. I'm Jennifer Zelnick from the Touro College Graduate School of Social Work, and today, on behalf of our research team, I'm going to describe an exploratory pilot training for social workers who work with drug-resistant TB/HIV patients in KwaZulu-Natal, South Africa. Okay, so first I'm going to talk about 4 aspects of the context for training, a few words about the context. The first is the terrible outcomes associated with drug-resistant tuberculosis and HIV treatment, which are driven in part by the harsh treatment demands like high pill burden, lengthy treatment, and adverse drug reactions, and also made worse by social issues that many patients face, like poverty, stigma, mental health, family problems, and so on. The second is the ongoing challenges of drug-resistant TB/HIV epidemic in KwaZulu-Natal and the rollout of new drugs, linezolid and bedaquiline, and the need to help patients on these new drugs, but also to protect these medicines against community resistance. A third aspect of context is the Praxis study. This training was part of the Praxis study, a trial of patient-centered intervention to improve outcomes for care for patients on bedaquiline, and was conceived of as a way to enhance the standard of care in the hospital where research is being conducted. And finally, the fact that social workers are part of the care team for patients and have a lot of experience working with social, psychological, and material needs of poor patients, but generally have received little health-specific training for their work. Okay, so we used a model for our training, and our model drew on 2 frameworks. The first was the idea of patient-centered care that considers the potential obstacles to care throughout the patient's journey along a continuum of care. Specifically, our training was based on the idea that social work skills could be used to support patients and help address many barriers to medication adherence and care. We also drew on the situated information, motivation, and behavioral skills model that has been used to improve adherence to antiretrovirals among people living with HIV/AIDS. And while our time today is way too short to fully engage with this model, I'll simply add that it informed the integration of treatment literacy and skills for motivation and behavior change in our training. Okay, and our training also built on the role that social workers already play in patient care, with the idea of deepening their knowledge and practices specific to working with drug-resistant TB/HIV patients. So the training was conducted in one day. Whoops, let's see. Okay, the training was conducted in one day by a team of 2 social workers, myself and a South African colleague who could not be here today. It included 10 social workers from inpatient and decentralized clinics in KwaZulu-Natal, and we evaluated the training using a pre-post survey, and we were able to follow up this survey 6 months post-training. We also gathered materials generated through the training for qualitative analysis. Here are some of the images of our beautiful social workers at the training. Our model informed topics for that day included understanding and refining the idea of patient-centered care, treatment literacy for drug-resistant TB medications, including common adverse reactions and approaches to mitigating them, skills for group work, and advocacy and self-care. We used an active participatory approach and a range of methods to create an open and safe environment for exploration and learning. So next, I'll share data on the training's impacts on social workers' knowledge, attitudes, and practices, as well as their insights on barriers to care and the social role in patient-centered care. So overall, looking at 10 indicators and comparing pre-post training surveys, there was a statistically significant change in their knowledge, attitudes, and skills overall. But specifically, we saw an increase in social workers' confidence in knowledge about TB medications and serious medication side effects. There was also an increase in social workers' intended practices, including the intention to talk with patients about medication side effects, help them plan for possible side effects, discuss specific barriers, and organize a patient support group. Now, while most of our changes, you may have noticed, did not persist after 6-month follow-up, intention to organize support groups did, and in fact, 2 social workers in our training planned and conducted a 6-session patient support group series as a result of this training. Okay, so social workers identified several categories of barriers, including barriers in the health system, barriers related to the treatment itself and related to patient hardships, especially poverty, and they mentioned that these were made worse by stigma and discrimination. And social workers also saw patient motivation to actively engage in their care as a barrier, which was sometimes made worse by a system that didn't value or incorporate the patient's own views on their care. And this is something that social workers really felt they could actively intervene on. In terms of their role in patient-centered care, social workers identified a strong role for themselves where they would use their skills to establish a warm, non-judgmental environment to support patient self-determination and to assess, counsel, and educate, and collaborate on individual, family, and community interventions as part of a multidisciplinary care team. So in summary, our one-day training pilot was effective in terms of improving knowledge and practice skills, though it appears that follow-up would be needed to sustain this change over time. We also noticed that social workers lack confidence in their treatment literacy and that this could impede their ability to fully support patients. Social workers also revealed their practice wisdom and experience for supporting patients, and they were extremely appreciative of and motivated by the opportunity for professional development, which they did not often get in their jobs within the public health system. And in closing, I'd just like to acknowledge the funding for the project, as well as the hospital administration and the social work staff participants. And there's our team. Okay, thank you, that's it.
Thank you, Jennifer. Unfortunately, we're out of time, so we'll hold any questions for the end. Sisse Tagabe in the audience from Addis. Okay, maybe we do have time for questions. Is there any burning questions for Jennifer, since we're missing a speaker? Do you have one?
No one has?
Yes. Jennifer, do you want to come take the stage?
Hello. Hi,
Hi.
I was just wondering whether you got any feedback on the social workers' engagement with the patients' families, and kind of whether they were sort of, because one problem is a lot of patients get excluded from their families and during treatment. So I was just wondering whether you had any feedback.
Right. I mean, social workers, first of all, felt very strongly about engaging families in, counseling and in the information around the diagnosis of the patients and so on. Our training didn't really touch on this, but part of what the social workers in the hospital do is reach out to families, in the event of problems with care and treatment. And so that's certainly something that they felt ought to be strengthened, and hopefully some of the tools that we gave them could assist in, effectively doing education and counseling on, on the treatment itself and some of the barriers and how they can best support their family member.
Thank you for that presentation. I'm just wondering, in terms of the interventions or the behaviors that didn't persist after 6 months, do you think that any of that had to do with the roles that the social workers perceived for themselves? Because I noticed that a lot of those interventions were more medically related, and when you get to the patient support group, which seems like a natural fit, that clearly that was something they were willing to continue.
Right. Yeah, I don't know if it's so much willingness, but I think it may be the opportunity to practice those behaviors and those skills and then to receive reinforcement. Because, although it's not their job necessarily to advise on the medications and the adverse drug reactions, there are others who can do that. Those things do come up in the context of the counseling that they do. And if they're not comfortable talking about them, that will, cut off a whole area of discussion, which, could be important. And frequently, social workers have that opportunity. So I think what that drop-off shows is that really would need to be supported further.
In the same context of the support groups, were these support groups facilitated always by the social worker, or was it also stimulated that they have their own group work among themselves, so empowering them as
Among
patients?
the patients,
Yeah.
right. Right, yeah, no, I mean, people love that idea, and it hasn't, within our model that didn't happen yet, but, these was a first step towards even having groups in the hospitals that patients could be a part of, so.
Okay, I just want to confirm Nebe Hiru, yes, great. Nebe Hiru is an M&E Senior Advisor at the USAID Challenge Project and works for MSH in the Ethiopia. Welcome. Can we pull up his slides, please?
Thank you, Nainin, for the chance to present our work from Ethiopia. The title of our finding is Treatment Outcome Patterns among Health Facility and Community or Health Post-Treated Tuberculosis Patients, and it's a group work of these individuals. To give you a background, in Ethiopia, Ethiopia is found in East Africa. It has a total population of 100 million, and the tier system looks like this. It has 3 levels of tier system: tertiary, secondary, and primary. As you can see from this, health posts are the most accessible to the community, and we are comparing patients, the treatment success rate of patients treated at health posts and health center and primary hospital, which are a little further than the people who are in their houses. Coming to the methodology, health posts are the smallest health unit. They are near to the village of the community. We have more than 70,000 health posts and 320 health centers and 270 hospitals in Ethiopia. Our national guideline promotes that each patient will be started at health center or hospital and is expected to be transferred to a nearby health post. But all patients are not being referred to health post. So we are comparing the finding from the treatment outcome of a 1 year data. Coming to the results, during the duration we have treated 120,000 patients in both health centers, hospitals, and community, which are health posts. The cumulative success rate is close to 92%. In the left section, it shows the treatment outcome among health posts, which are community-based institutions which are staffed by health extension workers. It is treatment success rate is 91%, and in health facilities, which include the health centers and hospitals, the treatment outcome is 92%. There is no significant difference between the success rate of patients treated at the community or health posts and the health centers or hospitals, which are staffed by clinical staffs. So the service they get shows that there is no significant difference among the outcome. Both outcomes are in line with the global and national targets. So this shows there is no significant difference among the treatment outcome in both those treated at community and health facilities. Coming to the conclusion part, as the graph shows, there is no significant difference in treatment outcome result in those treated at both groups, which is within the national and global target. So we are recommending further decentralization of patients to the sites where the patients are more accessible to, because both the outcomes are not significantly different among those groups. So this follow-up strategy should be enhanced so that each patient will be transferred to the health posts, which is more near to their patients. Thank you.
Thank you very much. We have a couple minutes for questions from the audience. Please go ahead.
Sorry, I have a lot of questions. So I guess one question I have, in your first slide there, or the second slide, when you talked about how patients were triaged, it said it was by preference where they wanted to be treated. So is that true, that the patients at the hospital had chosen to be treated at the health facility, or was it just that they had never been referred down? Because if it's patient preference, then I can understand the results very clearly. But if it's just that they didn't get transferred down, then I'd be interested in knowing more about the details.
Okay. Primarily, the patients are started at the point of their preference. Mostly, there is health centers and hospitals, and all patients are initiated in health centers and hospitals. And they are asked on their interest to go to health post which is nearby to their locality, because there are more than 70,000 health posts which are distributed along the country. So it depends on their decision. They can finish the treatment in hospital or health center or go to the health posts. So preference is the major criteria to decide where they continue their treatment after the initiation of the treatment. Because health workers, it needs counseling, you know. There is a feeling that any patient should be finish the treatment in health center and hospitals. So most patients are not voluntary to go to the lower level because they think the treatment they get is a little different from they get from hospitals.
But maybe it's also the phrasing. Further I think you mean scaling up, that health extension workers and health posts will give more the treatment when the patient wants to.
Yes, it needs health education and counseling so that the patients can trust those at health posts for treatment continuation. The first is patient-based care, you know. No. There is a trust issue. The problem is the understanding issue. So when we convince the patients that these health posts provide the same type of drugs, the same type of treatment to the patient which they get in health center and hospitals, they get convinced right away. But it's a counseling issue, a health educational issue, so that equal service is provided at the health post which is nearby to their locality.
Can I ask another question?
Okay, thank you.
Just one?
Okay.
Because then we need to continue the discussion. So what surprises me in the result is that the health facility dots is as that good. Were patients who are going to the health facility for DOT given daily one doses treatment, or were they able to take treatment home and come back after a week or something? What was the modality of DOT?
The modality of treatment during intensive phase, they are expected to come to each health facilities daily, yes. And they can assign a treatment supporter, which can follow their daily treatment follow-up during the stay. Okay, thank you.
Thank you so much.
Thank you.
Great. Our next speaker is Afifa Rahman Shepherd, who is currently at the Chatham House Centre on Global Health Security in the UK, primarily working on One Health and strengthening the implementation of the approach. With a master's in control of infectious disease, she maintains a keen interest in the field. Welcome, Afifa.
Good morning, everyone. I'm quite nervous because I have a lot of clicks, so please, I apologize in advance. So I'll be presenting on the topic of volunteer healthcare worker motivation and how this relates to the community's healthcare seeking experiences in Cambodia.
I think they haven't loaded your presentation.
Okay, it's starting. I will begin with a brief note on the importance of the health workforce and follow up with a model on motivational theory. From there, I will recall key findings from this study and end my presentation by demonstrating how these findings could impact TB control in a wider sense. A significant barrier to strengthening health systems in low middle income countries is the absence of a properly trained and motivated health workforce. Unsurprisingly, therefore, the health workforce is one of the WHO's 6 system building blocks that constitute the basic functions all health systems have to carry out in order to achieve their goals of improved health, responsiveness, and so on. Village Health Support Groups, or VHSGs, are Cambodia's equivalent to community healthcare workers and have helped reassemble the workforce post the Khmer Rouge regime. Despite playing a fundamental role in connecting the community with primary healthcare facilities, VHSGs are not fully integrated into the health system. They are local volunteers who do not traditionally receive any payment for their activities and work out of local health centers. So one of the questions we wanted to ask is, what motivates them? The complex process behind health worker motivation has been widely acknowledged in the literature, and its study spans several disciplines. Here I present a model to conceptualize motivational theory. Factors exist at each of these levels, but the key is the interaction between the extrinsic and the intrinsic. Extrinsic factors are said to be demotivating and the primary causes of job dissatisfaction, whilst the intrinsic factors are motivating and the primary causes of job satisfaction. How these two sets of factors interact influences one's overall levels of motivation. Previous interventions designed to improve worker performance have relied heavily on extrinsic motivators because income was generally thought of as the primary purpose of working. Essentially, the concept of paying to improve performance is built on the assumption that health workers need some form of incentive to perform, and it fails to recognize the array of factors that might be influencing their levels of motivation that cannot be incentivized with money. Empirical evidence increasingly shows that without the complement of non-financial incentives, financial ones alone do not maximize a worker's motivation potential. Cambodia introduced performance-based financing schemes in 2009 as part of public health sector reforms. This scheme demonstrated a positive correlation between larger incremental changes in a worker's income and their job motivation. However, a more comprehensive scheme was proposed due to the unexpected importance workers placed on other aspects relating to their community, the perceived value of their job, relations with their peers, and job training. A significant gap in the literature, and something we honed in on, is how motivational theory applies to different types of healthcare workers, i.e. volunteers, in various contexts, i.e. lower middle income countries, and health programs, i.e. vertical disease programs. We interviewed 14 VHSGs enrolled by Operation Asha, an NGO focused on TB control activities in India and Cambodia. These VHSGs deliver TB treatment, monitor adherence to medication, and essentially connect TB patients to the appropriate public health services and vice versa. We compared their perspective to 4 focus group discussions with community members from similar areas on their healthcare seeking experiences. VHSGs across both peri-urban and rural areas were immensely driven by intrinsic factors, as illustrated in a handful of quotes that will hopefully pop up soon. Now, not only did the VHSGs find the work self-fulfilling and enriching, they demonstrated altruistic and humanitarian-led values. VHSGs were very much connected to their community, seeking a sense of achievement, recognition, positive reinforcement, and appraisal, despite not being paid. The presence of these higher-level motives, as described in the literature, can in fact stimulate worker motivation in the absence of extrinsic rewards, creating an almost self-sustaining loop. When pushed, the majority of VHSGs chose to receive additional training, skills development, or free healthcare for their family over money. On the other hand, however, the role of VHSGs in their communities and their linkage to public health services was not substantiated in any way by community members during the discussions. The high level of motivation VHSGs exhibited was not reflected in the community's healthcare seeking preferences, indicating a gross weakness in how the primary healthcare system is functioning. Communities that are unaware and uninformed of their healthcare seeking options tend to unintentionally misuse the health system, seeking care through inappropriate channels that put themselves at financial risk, B, have knock-on effects on service delivery and quality, and C, most importantly, they might not reach the right care in a timely manner, all of which burden an already fragile health system. The disconnect between VHSG motivation and the community's healthcare-seeking behavior suggests that the full potential of VHSGs is currently not being realized. The majority of high TB burden countries share this profile, whereby the number of notified cases is lower than the estimated number of TB incidence cases to varying extents. In Cambodia, at best, the gap is minimal, but at worst, the gap is 200,000 missing TB cases who continue to go undiagnosed and untreated. If the health system, let's say, responded to the intrinsic drive of VHSGs and maximized their motivation, they have the capacity to improve community-based TB care and begin closing the gap between what is estimated and what is notified in TB. Not only in Cambodia, but perhaps in any country that is overlooking the role of community healthcare workers in vertical disease programs. Thank you very much.
Is Layla here? Okay, so we also have our last speaker is missing, which gives you plenty of time for questions. So let's go ahead and open up the floor for Afifa, and then if anyone has questions for our other speakers, it can be open as well. Thank you.
There's a gentleman in the back.
Hi, thank you very much for that really interesting presentation. My name's Tom Wingfield from University of Liverpool. Tried to do similar things in Peru and often found sometimes retention was quite difficult of staff because of the very reasons that you mentioned if people aren't acknowledged perhaps for what they're doing. I was just wondering what you thought about the role of the volunteers, thinking that perhaps the work they're doing at present, even if it's not paid now, may in the future, as a skill or a part of training, lead to employment or lead to further opportunities, and how much that could influence their satisfaction.
Yeah, I think, immediately what I thought of is that the sort of debate around financial incentivization for volunteers, and that opponents think it goes against public health ethos and that it will actually degrade that and sorry, I'm not sure if that's me. So it wasn't something that we explored. We asked them a series of questions that was very much focused on their present work. And I think it would be an interesting thing to then look at, okay, so maybe there's you can build in incentivization in terms of your long-term contributions. So I think that's an interesting way to go, but I wonder how the debate or the opponents and proponents would view that, in the sense of whether it still kind of affects public health ethos, etc.
And sorry, just a very, very quick question. What was the gender makeup of your volunteers in terms of how many were women? Sorry if I missed it.
No, I didn't mention it. We tried to achieve a balance. Unfortunately, I think the majority were male. I think it was, we had 5 females and 11 males. So that could, affect results in various ways.
Thank you for that very interesting presentation. And I think in terms of your findings, it's very similar to what we found in working with pharmacies in Cambodia. And I wonder how much of that is related, how much of the motivation that you see in these particular groups is related to their very Buddhist culture.
Yes.
And how that might translate to other countries, because we have not found the same level of motivation amongst health workers in other countries.
Yeah, it was definitely something that I included in the discussion, that of course, cultural factors, religious factors, and how they view the afterlife, that sort of spiritual content to their lives would definitely possibly play a role. We're looking to conduct a similar study in Pakistan, so that might provide some sort of comparison, but there were a lot of things, a lot of very interesting factors that can go into this sort of intrinsic motivation and what it means. I think that's part of why there's a gap maybe in the literature that we were hoping to fill, in that studying motivation in volunteers in different contexts will hopefully provide a wide array of different results. Sorry, on that as well, I didn't put any quotes up, but there were quotes that specifically talked about or could be seen as being linked to Buddhist culture, in the sense of this is me giving to my community, I have the humanitarian in my heart, those sorts of things that kind of imply there's a spirituality to it.
Thank you so much. I find it a bit reaching a balance between extrinsic factors and intrinsic factors to make sure that the healthcare worker indeed operates is always a difficult issue, because where I'm coming from, I think people who are volunteers, you see that the turnover is very high, because whatever comes up that can put money in their pocket, they rush to do that. And therefore, much as someone wants to do your TB job or HIV job, indeed some of these factors are always at play. So I'm not sure if how you can, what you can say about this in order to reach a balance between extrinsic factors and intrinsic factors.
Again, that was something we noticed in the literature that was lacking, was, A, what is the motivation of volunteer healthcare workers, and B, what kind of a balance can you provide? Because as I said, in Cambodia and in previous interventions, it's been very focused on extrinsic rewards, and A, not acknowledging that there are intrinsic factors, and B, not sort of thinking about a balance, and that it doesn't have to be one or the other. I think something interesting that we found was that some of our male VHSGs were the chief of the villages, and they were therefore a little bit more candid and would acknowledge the fact that yes, money in the pocket is great. So there is that, there are a lot of ways I think that you could push a little further and find out, maybe more exactly what that balance could be. But I agree with you that, perhaps a limitation of the study was that VHSGs were, their supervisors were in fact present where we were conducting the interviews, which may have led to them sort of being a bit embarrassed and ashamed. I'm so sorry. A little bit embarrassed and ashamed. Over here? Okay, thank you. So they may have been a little embarrassed or ashamed to actually ask for money. So I think that, there are better ways to maybe control the study, which you could then draw on specifically what the role of money is and how you can achieve that balance. Another question here? I think he's just coming to you.
Yeah, thank you for your very interesting talk. And I wonder, did you also go into the question what's the appreciation of the community for these community healthcare workers?
Yeah, there was zero mention of the VHSGs by the communities. They were primarily, I didn't go into this too much for this presentation, but they were primarily occupied by private healthcare services and their complaints and qualms with that sector. That was their first point of call. That was the first place they'd go to. It completely determined their healthcare seeking behavior. They also complained about public healthcare sector services in their areas, and there was no mention of not VHSGs by name or community healthcare workers. So even when pushed.
So that was not the intrinsic motivation of the community health workers, that they got a sort of, acknowledgement from their community.
I see. But it was interesting because there was a complete disconnect because they felt that they were very much valued in their community and they perceived the community to treat them well. So I think in terms of the one-on-one engagements they had with community members, yes, they felt that there was that appreciation. But when in the focus group discussions with the whole, a variety of different community members, there was no mention of them. That wasn't reflected at all. So a complete disconnect.
I find it very interesting because it's amazing that nobody knew this role. So what were... here we are. What were the roles of these community health workers? Was it awareness raising and patient support, or was it mainly patient support? So the community members maybe don't know if because it's more related to patients, TB patients?
Yeah, they have. So they are. The community members there were also focus group discussions conducted with TB patients, and I haven't gone into that. So there was that perspective as well. Also, lack of mention or not reflecting the equal motivation that VHSGs had. So VHSGs, this group were enrolled specifically by an NGO focused on TB. So their activities were TB focused, but it also extended to active case finding and sort of knowing very well their community and what the levels are, etc. So they had a role in terms of engaging widely with the community to go to house, door to door, village to village to find TB patients and look at symptoms, who's coughing, that kind of a thing. And also working with the local public healthcare posts or centres. So in that sense as well, there's a disconnect where the public sector isn't integrating them and taking them on board to then send out further reinforcement to go back into the village. So
Did they work with leaders also?
they worked with the village chiefs, but some of the VHSGs were village chiefs as well, which you think would help, but perhaps didn't. Yeah.
Okay, do we have any questions for Afifa or for any of our other panelists? I know some of the audience came in late. Okay, I had a question for Jennifer, if it was okay. The training that you did, so that was kind of a pilot or a one-off. What is your plan for kind of next steps, I guess, given its relative success?
So following that one-off training, which occurred in April of 2016, we did have a follow-up group skills building with the social workers, and then a subsequent follow-up meeting looking at other aspects. So for this point in time, that sort of completes our work with them. But as I mentioned, this project was also part of a larger study, the Praxis study, which is trialing an intervention to improve outcomes, and it incorporates social work skills within the intervention. So, the social workers will play a role in that, as these are patients from their hospital. So, these efforts were intended to kind of improve their practices within the standard of care within the hospital. So.
The materials you used, I think this was a very interesting. I'm interested in the way and approach and the materials. Is that's available? For example, we are working in Central Asia, in Kazakhstan, where we have also the social workers and want to include them in patient-centered care. So I was just very curious to know if we can access or exchange that. Okay.
Another question from the middle, thanks.
Just a question for our colleague from India. In terms of thinking about the decentralization models, now with a very ambitious plan for scale-up of treatment in India, what do you think about changes in policy to avoid the hospitalization for initiation of treatment at all? Because that will be where the bottleneck, I assume, will occur. And so is there any thinking around that, or any research on looking at ambulatory care from day one?
So the current plan is we'll have nodal DRTB centers as well as district level DRTB centers. We've already started implementing, forming district level DRTB centers at 4 districts, and this is being scaled up and at all districts, as well as the DRTB committees in all districts will be functional. So the treatment can be started from day one itself, from the same district, instead of the patient do not need to travel far off to the far off DRTB centers. The linked district level DRTB centers can take care of the same.
Any other questions? All right, if we could have a last round of applause for all of the great speakers, we really appreciate that. Thank you again for all of the great questions. I thought we had some lively discussions, and I hope you enjoy the rest of your conference on behalf of Neddy and myself. Thank you very much.
Underwater.